Welcome to Clip 5 of the International EPA course. As was already covered, EPAs are what bind the competencies possessed by learners to the practice of our professions. They must be suitable to professional credentialing when applied in competency-based training. It should be clear from this that it is crucial that we carefully describe and define EPAs using a format that supports this high-stakes application and builds a clear shared understanding of what the activity is. As we go along, we'll use several examples to highlight important points. So let's dive in. When we think of EPAs, we often just think of the title. When we think of an activity, we all carry what's largely a tacit understanding of what that activity should look like. The problem is, as assessors, clinicians, competency committee members, we often have significant differences in this understanding, or differences in the standards for calling a learner's performance competent. In fact, these differences in understanding an EPA can have implications from the learner through supervisors, competency committee members, and credentialing bodies and colleges. If we are to use EPAs towards their intended purpose, we need to clearly elaborate the definition of each EPA and provide a clear shared understanding of what we're aiming for. Fully elaborated descriptions of EPAs have the same basic elements used 10 years ago, such as the title, detailed description, and specification. However, experience we've gained has identified areas for revision and some new aspects to be included. Here you see the 8 components that should be defined when fully elaborating an EPA. Some of these are more intuitive than others. We'll look at these one by one to clarify what it is, why it's important, and how to address it effectively. The EPA title. A succinct, unambiguous, and well-written EPA title is essential. With just the title, the activity should be intuitively recognized by learners and supervising clinicians, as well as others such as regulators, examination boards, and nursing staff. It should read as a generalized activity, not as specific to a person or context. For example, assessing and treating emergency department patients with hypotension. Here you see a couple of qualifiers in the title that don't really add much. Emergency department just provides a context for the activity. And hypotension specifies a particular patient. Although it may be very important to see a learner successfully manage patients in the ER and patients with hypotension, these are simply contexts for a larger activity that might be written as assessing and treating patients with acute medical presentations. Addressing the specifics is done through how you sample from a learner's various clinical activities that they have assessed. Here's another example. Assessing and treating frozen shoulders in the ambulatory setting. It could be better written as assessing and treating large joint injuries. Again, sampling and assessing the EPA may require learners perform this EPA on a frozen shoulder, but avoid putting such specifics in the EPA title itself. The more specifically you write your EPA titles, the more EPAs you will have and the more complicated things get. Here's another point to keep in mind when writing your EPA title. We recommend you use the continuous verb form and plural. Consider this example, assessing a patient using echocardiography. Here it becomes assessing patients using echocardiography. Structuring titles this way emphasizes that a formal entrustment decision on an EPA is not just for a single patient at one time, but is ongoing entrustment for that task across different patients. Here it's possible to be even more succinct. For the above example, a title of just echocardiography may be sufficient to provide all stakeholders the required understanding. Finally, avoid a chain of interrelated activities in the title. Consider the following Global Health EPA. Engaging with stakeholders to support strategic planning that addresses locally identified priorities. It's not clear if the activity is stakeholder engagement, supporting, strategic planning, or addressing. This ambiguity will translate into problems in assessment and adjudication in awarding the EPA. Aim to keep the title a concise statement of one concrete activity. Specifications and limitations. As you can tell by the label, this is where the details and breadth of the task are specified. Differences in how supervisors, programs, and credentialing bodies interpret an EPA can potentially lead to harm for patients as well as trainees. Beyond just the title, a clear and shared understanding of the EPA is essential. From learners to program leaders, anyone performing or assessing the EPA should know what's included, what's not included, in what context is the EPA expected, and any limitations on the EPA or situations where a learner certified for an EPA may not actually be endorsed to perform it. The details of an EPA can be specified and described in different ways, depending on what makes the most sense for that particular activity. EPAs that are single tasks can be specified by simply chronologically listing the steps to performing the EPA. For EPAs that are bundles of tasks, such as the general procedures of a physician, begin by describing the common elements that make those tasks an appropriate bundle. For the example of general procedures of a physician, you might start by describing common pre-procedure, procedural, and post-procedure tasks, and then simply list the specified procedures that are included in the EPA. Limitations. Limitations is about setting the boundaries on the scope of the EPA. These may include elements or situations under which the individual is not necessarily qualified to perform the EPA, even when certified for it. For example, a procedural EPA may limit certification to performing that EPA on certain patient types or setting. A pharmacy EPA for patient counseling may have limitations related to different classes of the medications. For example, chemotherapeutic agents may require specialized training. Potential risks in case of failure. This gets to the fundamental aspect that these activities are entrusted to learners and health professionals. For an activity to be entrustable, by definition, there must be an at-risk party, someone who may not always be front and center in assessment discussion. In making entrustment decisions, it is essential that the potential risks are explicitly articulated and considered in any decision to award or certify a learner for this EPA. Too often, assessment discussions focus on the implications for learners, and promotion becomes the default outcome. By clearly articulating the potential negative consequences of entrustment decisions, we bring the patient into the decision, and we raise the bar for awarding an EPA. Most relevant competency domains. The last 20 years have seen broad adoption of competency frameworks across many different health professions. As was discussed in an earlier clip, EPAs do not make competencies or competency frameworks irrelevant. Instead, EPAs link these competencies or abilities, which are possessed by an individual, to how he or she practices their profession. These frameworks remain crucial to schools and training programs for directing curricular development. Competency frameworks may use different terms and classification, but they all share a branching structure that takes the profession and breaks it down into large domains and subsequently smaller and more granular descriptions of the underlying competencies. The CanMEDS framework is shown here as an example. Almost all EPAs will require learners to integrate multiple domains of competence, often all of them. But in this section of the EPA description, we ask only for the most salient domains. In identifying the most important domains of competence, we help guide more focused assessment of the EPA. This approach also recognizes that a given EPA is only one in a collection of EPAs for the profession. Mapping all of the EPAs in a program against the competency framework generates a matrix that allows you to see where learning and assessment of different skills in a curriculum must fall. This matrix, in fact, provides content validity evidence for learning and assessment within the program. Required knowledge, skills, attitudes, and experiences. The previous sections dealt with aspects of EPAs that largely focus on assessment and decision-making around awarding EPAs. Here we shift gears a little and bring more attention to learning. EPA descriptions must be more than simply a performance standard for summative decision-making. They must also provide direction for learners and teachers around the abilities that need to be acquired to perform the EPA. The EPA specifications that we listed in Section 2 carefully detail the professional work the EPA represents. In this section, we shift from describing the work to primarily describing the learner. The knowledge, skills, and attitudes, or KSAs, focus on the foundational abilities they must possess to perform the EPA. Experiences is also included here. Although experiences are not possessed by the learner per se, many EPAs, particularly procedural ones, require learners to accumulate a volume of experience to achieve competence. Colonoscopy is a well-established example. Although this appears at a superficial level to move away from competency-based approaches, it simply reflects Erickson's work that shows high proficiency requires much practice, and that quality and quantity of experience can be reasonably demanded prior to considering entrustment. It should also be noted that we cannot assume competence simply because a certain number of procedures or experiences has been reached. One final note. The knowledge, skills, attitudes, and experiences section serves an essential role in guiding curriculum development. Those doing curriculum development in an EPA-based program should ask, does the curriculum adequately prepare learners with the knowledge, skills, and attitudes and provide opportunities for practice leading up to the point where we expect learners to demonstrate performance? Sources to assess progress and support summative entrustment. In this section of the EPA description, you are outlining what you believe are the information sources required to make a well-grounded summative entrustment decision. What sources of information and assessment tools should be used? How many times must an EPA be observed? Who will make summative entrustment decisions? When you first implement EPAs, this is a particularly challenging task to take on with little empiric data to guide you. It will rely heavily on expert opinion. As you gain more experience using EPAs, this section can be revised to reflect the knowledge and data you gain in operationalizing them. Later in the course, we'll talk in greater detail about assessment, but here I want to highlight a few principles. First, aim for diversity in the assessment tools and approaches you include. The table here highlights a variety of approaches and tools you can choose from. Second, make sure it's feasible. 20 direct observations of clinical encounters per week per student is not likely to be possible in most training programs. A good source for more details is Hombo, Durning, and Hawkins' book from 2018 on assessing clinical competence. When laying out the assessment requirements, it's important not to simply think about the types of assessments you want to include, but also define the numbers expected. There is no one-size-fits-all for the number of assessments needed across all of the EPAs. Even for one specific EPA, an advanced learner may demonstrate readiness for entrustment with less data when compared to another learner. Nonetheless, given the significance of certification decisions, some agreed-upon quantity of assessment must be included for each EPA. There are a few important considerations that can help ground decisions on the numbers of assessments targeted for summative entrustment decisions. First, consider the breadth of possible contexts, like patient presentations. You do not want to sample all of these, but you do want to ensure that there are sufficient assessments of the EPA to capture a sample that is representative of the profession or specialty. Second, it is important to have enough assessments that educators can have confidence that the learner is performing the activity consistently at the standard expected. That is not to say variance will not occur, but a holistic review of the assessments should capture consistency. Third, the sample of assessments should also capture the different perspectives required to formally entrust the EPA, including assessments from allied health professionals, patients, and/or peers may be appropriate for some EPAs. This should be accounted for in the assessment plan. Fourth, the stakes of the entrustment decision are important. Entrustment decisions in which the learner will remain supervised in some capacity may require fewer observations to ensure safe patient care compared to certification of an EPA for unsupervised practice. Entrustment or supervision level expected at which stage of training. The essence of this section is to support an individualized and practical application of the EPAs to the program's curriculum. Here you want to answer when trainees are expected to reach a given level of entrustment or supervision for a particular EPA. In many countries, Level 3 or indirect supervision lines up with the end of medical school. Level 4 represents going into unsupervised practice at the end of residency. And as a reminder from previous clips, here are those 5 levels of entrustment. For each EPA in a program, a map can be made identifying when indirect or distant supervision is expected to be achieved. Identifying where and when in a curriculum these EPAs can reasonably be expected to be achieved provides guidance to both learners and supervisors. From this protocol, and in consideration of a given trainee's individual record of learning experiences and rotations, deviations in expected development can be identified. This can inform decisions on how to personalize training experiences and support progression towards certification. This individualized approach should also empower trainees who are being regularly assessed to ask for promotion when they feel they are ready. Encouraging trainees to request certification at the next level of entrustment for an EPA, which can be considered and awarded if the committee feels there's sufficient grounding for it, promotes self-regulation in the learner. Time period to expiration if not practiced. This section is less locally determined and more general than the last 2 sections because its significance extends beyond the educational program. Several EPAs require sustained practice to remain safe and competent. Evidence of this has emerged in both procedural and non-procedural professions. In other words, a decision to entrust a trainee or graduate with a critical or complex EPA, even if well-grounded, may not hold true over time if not practiced. For some EPAs, practice needs to continue every week or month to maintain skill. For others, a few years of non-practice may not be very critical. This is variation among EPAs, and expiry dates may need to be set for EPAs individually. What is the significance of an expiry date? A summative entrustment decision is meant to support the future privilege of unsupervised practice, just as a medical license or specialty board certification does. So what should be the consequence of an EPA that needs maintenance but is not practiced for several years? Either the practitioner can decide to leave the EPA outside of his or her scope of practice, or, if so desired, he or she can seek supervision long enough to reestablish that trust. The educational institution can set the expiry date, but cannot enforce sanctions if the practitioner desires to pick up an activity after a long hibernation. Regulatory bodies other than the educational program may choose to set rules to enforce safe patient care. This section of the EPA description can only serve as a signal. Here we show an example of how one can lay out a fully elaborated description of an EPA using an example from emergency medicine. These templates are easy to create using productivity software such as Microsoft Office or Google Docs. This brings us to the end of Clip 5 of the online EPA course. To summarize, we've gone over the 8 components of a complete EPA description. We've talked about how to approach each of these components and why each is important. For a more in-depth review, see the upcoming AMY guide, the recommended description of an entrustable professional activity. Here are some useful references for this section.